everybody. I am happy. I've got an old friend who was on here, psychiatrist, no noise making, but a great psychiatrist. He and I have talked about the issue that is behind this workshop for years. And so the name of the workshop is Progressing Beyond Symptoms, Treating the Core of Addictions, which will take place on Saturday, June 19th from 10 to 11:30. So Dr. Lawrence Peacock is with me. If I slip, I may call him Larry because that's what we usually say with each other, and he has other names for me. So
I call you Larry as well.
Larry,
it's really odd.
That gets a little confusing at times, but we work
Thank
at
you,
it.
Larry.
You know? You want to just do a quick introduction to yourself, Larry, and
yes,
and then I'll do engage in avoidance and not do mine. Okay.
All right, wonderful. So I'm an adult psychiatrist, and I'm currently the chief medical officer at SCAD. And SCAD is I need to pitch for SCAD, but it's we treat all phases of addiction. So we're located in southeastern Connecticut, and drugs, alcohol, but we have a detox program. We have a long-term 90 days is typically what we think, but oftentimes longer than that. So we have 100 beds, approximately 100 beds over there. And we have outpatient IOP and all phases. And so this is something that we take along a continuum. So we're not just thinking about detox and treating people. We really think about, because detox is just the beginning of the process. And we really think about getting them through that safe medical detox and then how do we treat them. So that's my primary hat that I wear most days now. But my background is fairly varied, including I had briefly worked as director of psychiatry at a level 5 prison in Florida. And the amount of really addiction issues in the prison system is probably not shocking to anybody. But at the base of that stuff is what we're really talking about. So that's the stuff that you and I have been engaging in a long time, and that's early developmental history. That's trauma stuff. So that's probably the core of my big interest is trauma. And my background also includes, I had gone to divinity school as well. So I have been exploring the very nature of who we are as people in the context of psychosocial and spiritual values and relationships. That's it.
Good deal. Good. Thanks, Larry. I'm Steve Johnson. Not a psychiatrist, I'm a psychologist. I've licensed as an addictions therapist as well as marriage and family. I think I got started with marriage and family to be quite interested, very interested in that. Although first doctorate was in philosophy of all things, philosophy of mind, and that got me interested in psychology et cetera. And I became really very interested in PTSD, treating PTSD, and if you treat PTSD, then, you know, substance use disorder is one of the major co-occurring disorders with PTSD. So I became very interested in that. And now I'm a professor and chair or direct the master's in addictions counseling, and also work as a president of the Albert Ellis Institute. So very grounded in those second wave behavioral models. But Larry, I want to begin with, as we give a little bit about what we'll be covering in this workshop. And one of the things that I've noticed when we're looking at treatment of addictions, and when I look at the literature, lots of talk about the cravings that clients have, and what do we do with those cravings, or the habits that they develop behaviorally, and then also impulse control. And then we want to just find ways to decrease cravings, have them develop greater impulse control, and break habits, right? But one of the factors that is usually missing is that I've seen present in addictions, and I think is core, and we've talked about this, is frustration and tolerance when dealing with addictions. Why do you think just looking at cravings, habits, and impulse control is kind of an incomplete approach to dealing with addictions, and why is it important to even address frustration and tolerance at all?
That's a great question, Steve.
Long question, I know, but I hope it makes sense.
I actually, I would like to rewind a little bit and to think about some of the reasons why we might be calling something frustration intolerance and kind of unpacking that a little bit. So we often talk about, you and I talk about evolutionary psychology, evolutionary biology, and how did we get where we are in most models of psychotherapy, psychiatry, in addiction medicine as well, has what we think of as fairly downstream and fairly reductionistic approaches. So in psychiatry, we try to find the molecule that is missing. We try to figure out the pathway that is broken. And we never think about that pathway or that molecule as being exactly adapted for the person who arrived in that space in that moment. And when I say that person, and this is challenging too, what is the nature of self? And that's something we often get into. But what allowed that person to get to that space right there that they're experiencing that? So it's not just who we think of them in that moment as the adult who's struggling with addiction. It's really their entire history. It's their family history. It's their cultural history. It's all these things that get passed down. We're talking all the biology and all the stuff that arrived to this. So early on in our, if we just go back to just childhood, it's a good place to start. But I oftentimes make the argument that we're talking transgenerational trauma, transgenerational biology, changes that happen that were exactly adaptive, that we now call maladaptive, but they were exactly adaptive for the species, for the person to survive. So reframing is the first thing I like to do when we start talking to people about how to treat this, because if you don't understand etiology, and etiology is really the underlying cause, then you make some fundamental errors downstream because you start seeing correlational patterns. So frustration intolerance is a correlational pattern. We see people that have low frustration, they get really triggered, they get really reactive, but what they're experiencing at the very base is some level of threat at the interface, some level of threat. And then they start to get upset quite easily. Threat, interface. Then they start to do some pattern of seeking behaviors that make them feel safe, which those patterns that made them feel safe was habits. So we get caught up in these habits all the time. So some of the mechanisms by how we treat what we call frustration tolerance instead of threat, seeing threat within the interface, is we start to think about urge surfing. You hear people talk about that. They'll say, oh, okay, so when you start to feel threat, feel these feelings with a real curiosity and be able to sit with it. But I want to know why they got there from the very beginning. So one of the things I want to help people unpack is understand exactly what was adaptive, allowed them to arrive where they were. And if you look at our history, and if you really look at our history, and I'm not talking 10, 20, I'm talking thousands of years ago, if you look at our history, humans were, what allowed us to be adaptive was our relationship to other human beings. Hypersocialization, we're the most hypersocialized animal, more so than dogs, more so than horses. Humans were hypersocialized, and it allowed us to be really adaptive. And what do we mean by that, and how does that play out currently? When children are born, and I don't get into the attachment stuff, well, maybe a little bit, but when children are born, they learn to regulate their nervous system. And their nervous systems learn to be regulated in the context of another relationship, a primary caregiver, the mother oftentimes. And it learns to those primary drives. How do I regulate those primary drives around discomfort, hunger, things like that? And it's in the context of those needs, and they start to develop a capacity of that relationship, that hypersocialization that we talked about, that they began to have this projection or understanding of self in the context of others. You'll see downstream, people with poor frustration tolerance is embedded in their early developmental history. So they start to experience threat, easily threat. So they see, and psychologists like yourself use words like external locus. And what we're really talking about is something in the environment which will bring relief to this person is seen as not being met in that moment because of safety needs being met, or whatever it is, but they're seeing threat. One of the key things for decreasing frustration tolerance is the capacity to be able to not experience threat in the context of an environment in which they believe they would have some sort of source of making the environment safe. Whatever it is, whatever the environment would make it safe. And then we get into those patterns, those habits of drugs, food, addiction, sex, whatever it is, right? We get into these patterns, but the patterns began around their construction of self, if that makes sense. So they feel threat where other people may not see threat. So community is a really fascinating, the research is really interesting. When people feel safe in the context of relationship with other people, you start to develop community, connections, relationships. Frustration tolerance actually improves. The capacity to be, when people feel more disconnected, the capacity to be able to tolerate frustration goes up. So we see that like during COVID, high rates of relapse, high rates of loneliness, isolation, and poor frustration tolerance. So I think one of the core things that I would like to really push back on is the labeling of these experiences around threat. So we call it frustration tolerance, intolerance. So the ability to tolerate frustration isn't really about that. It's really about, how am I experiencing this thing, this context of safety? I don't know if that all makes sense.
Yeah, so one of the ways as I'm listening to this, and we've talked about this over and over, is these patterns of threat. And so even some kind of generalizations on threats, that things that are functionally not a threat, right, we develop patterns of seeing these as threats. And then also ways of seeing the self as unable and to handle those threats because we are disconnected from others, so we have to do it all alone anyway, right? And so we build this this construction that is guaranteed to fail in many ways. And if in treatment we're saying yes, of course you're going to fail because this is an overwhelming threat. That is, you are seeing things rightly, and in fact it is such an overwhelming threat, you must never be triggered, right? You've got to avoid that, at least initially. So really kind of an unreal life that we're inviting them to kind of live, right? And seems to be a little bit problematical, but you're describing something as seeing threat where there is threat. But even when we see threat, we don't view it as just an overwhelming threat, right? That there
like what you're saying.
There's often much that we can do. In other words, opportunity, so that we can handle that environment, effectively to reach the goals that we want to achieve.
So, Steve, let me highlight on a couple things you just said that I really liked. So we typically will say that you're going to continue to experience what they have seen in the interface is threat. This is threat. You're going to, the expected course of your struggles with addiction is that we don't change the interface. The current model says that the world you see is accurate. And we know that's not true. The world you see has been the world that was necessary for your early survival, but it may be the least adaptive, even at a physiological level, the least adaptive for your long-term survival. And that's all likelihood really true. The things that allow you to mobilize yourself to get out of threat are the things that take a considerable toll on the human body. If there's a car coming after you, it takes a considerable toll initially, but you have resolution. If you chronically believe that there is a car that's going to hit you, your body's in a state of heightened arousal. So we're saying to the people essentially is that the environment that you believe, the perceptions that you hold, that you will continue to have these interfaces in which you see threat. And that's a challenging model to kind of shift away from. So that's one of the things I would like to challenge people to say is that the world that people see is the world that they were programmed to believe that they live in. Much like, we talked oftentimes about the allegory of the cave. It is just that. So the other thing is that if you have chronic levels of cortisol, so we know that chronic basal cortisol, the basal level, we're not talking those spikes that people can experience and have resolution, but that chronic upregulation, that HPA axis upregulation, is that will affect the way you interpret the environment. So if I can just merely increase your cortisol levels, you'll start to experience either heightened levels of arousal. It doesn't have to be threat, it's just heightened levels of arousal. But people that have this built up emotional cognitive complex that they've built will interpret that heightened arousal. So even a vacation can be a source of relapse, a job, a promotion, because of that increase in cortisol. So you'll find that, which is really fascinating. A person will get a promotion or take on a new relationship, and they'll say, and they will take ownership of it as some sort of moral feeling. Like, why is it when I get a job that I want? Or why is it when I get a new relationship, I self-sabotage. And we use words like self-sabotage. It's not self-sabotage, right? And we'll create all these cognitive, we'll come up with a really interesting narrative, and we will try to do some mind reading techniques. But I know if I just simply increase cortisol levels, arousal-based levels in a human, if I could do that, exogenously, give you increased levels of stress hormone, whatever your functional paradigm, how you built up your emotional complex, you will start to have those patterns play out again. So if your interface is primarily threat, in an interface in which you could be having engagement, excitement, you'll see periods of relapse. And so you'll see those people that will get a new job and literally say, why am I doing this? I found myself drinking again. I can't manage my stress level. I can't manage this. The interface that they've been practiced into, the way that they experience this world, is to see threat. But on the opposite of that, there are people that have built their entire emotional system, and we talk about this often, that they see engagement opportunity because the allegory of the cave, the thing that they see, is a different world. The model of psychiatry, psychology that we're teaching people in addiction is that you will continue to see threat. You'll still see the same shadows on the cave, the exact same stuff. Expect that to happen. That's this is a paradigm shift to say, I want you not to see the same cave. I want you to understand that the wall that you see, the matrix that you see, could be a vastly different one. And so when we start to talk about frustration, tolerance versus intolerance, what we're really talking about is a paradigm shift, because we want people to start to see themselves as connected to community, relationships. And we know the research is really clear. Rat models all the way up to human models. When people start to shift the cave to now seeing the wall as being, I am interconnected to other human beings, then frustration tolerance goes up. They don't even call it frustration, it's engagement.
Yep.
And the idea of intolerance is literally shifted to a different experience, which is really interesting.
Yeah, and so even if a person doesn't have substance use disorder, okay, what are the deleterious effects of cortisol over high levels of cortisol over a long period of time? A person might say, well, that's just the way I'm created. You know what I mean? I'm just type A, and I'm just, I'm just pumping cortisol. That's all I do. That's just normal for me. Is there any motivation to change that? Or do we just say, yeah, that's me, there's no negative effect of having, cortisol highs all the time.
The interesting thing is that, again, this is all downstream stuff,
Yeah.
right? So people talk about good stress and bad stress. Actually, they even use the word stress is a label for a physiological response to it. It's nothing more than just a response. Excitement, engagement, those are also physiological engagement. Those are the alerting system responding to something in the environment. When I use the word alerting system, I'm really talking about motivating let me take that back. I'm really talking about activation of the sympathetic nervous system for whatever it may be, right? But the research on good stress versus bad stress, if we're going to use that language, what they show is good stress doesn't have the deleterious effects that you're talking about. People believing that stress is not bad for them. Again, that's downstream, right? So what I'm saying is the people that would believe that stress isn't bad for them have a different early construction understanding of self. And so you'll find in the literature, and people will use terms like secure attachment, they'll talk about that. But what they really learned is that they do not experience threat in the context of others. They do not experience this, what we typically think of as external locus, or the model of being always under attack, or the model of seeing themselves as a prey, or the model of seeing themselves within the victim narrative, that they don't have this construction, this belief that who they are. So their physiological response is that they have resolution of that. And the resolution of that we've known early on in animal models and human models is oxytocin. And so we get little talk about oxytocin in the addiction models. Very little talk. I don't hear a lot of literature around that. There is literature, but I don't hear a lot of talk about it. And that stress hormones are not bad for you. They're not, and that's probably shocking for people to hear, that stress hormones have actually beneficial effects for us. It's the term is called hormesis. So exposure to things that are typically considered deleterious, harmful for you, can have what they call a hormetic effect. it can actually strengthen you at a cellular level, which is really interesting. And you can see that model applied to other things, to the immune system, to even psychological immunity, that adversity builds strength, and it actually literally builds strength within the nervous system, within the cellular level. So cortisol is not bad. Cortisol that's unremitting chronic levels of basal level of cortisol, we know that that's very bad, and without resolution of that. So it actually it decreases the length of what's called telomeres, and those are the caps on the DNA. They actually increase aging process. So people chronically under what we've been labeling as stress, which is really activation of the sympathetic nervous system, is decreasing long-term survival. People don't do well. And then all the patterns of getting some sort of safety in the world, patterns of dopamine-seeking behavior, also increase the likelihood they're not going to live long, whether it's smoking or drugs or carbohydrate-rich foods. So people oftentimes dopamine sugar. So sugar is an inflammatory process. So all of that's interesting. So cortisol is not bad. The word stress is not bad. It's the lack of resolution of the sympathetic nervous system. So frustration, and if we get back to the idea of tolerating frustrating events, seeing threat. So what we're really experiencing is a person who is already at a state of heightened arousal, basal level heightened arousal. So, and they're looking for something that they have a perceptual understanding that will bring safety into their life. I got to get blah, blah, blah. They're in line at a store, they see threat, other people around, if. So they have a basal cortisol, they see threat. So they have this reaction, anger, some pattern. Then what you talk about is habit loops, things that bring resolution of that. They're like, I couldn't believe I was so upset at work today. This didn't happen. The boss, blah, 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 blah. And I relapsed. But we never taught them that the interface of threat. So it really has to do with this threat interface. Really interesting.
It is. We just have a few more minutes, but I wanted to bring this up because you didn't use the term, but you talked about the reality of these adverse childhood events. And, here you are, a little kid, and you're looking up at nostrils of people that, were supposed to create a safe environment for you, and they didn't do it. And so you learn to be very quiet because whatever pops out of your mouth might, end up being a real threat for you, right? And so which was adaptive then, but later when you're not looking up nostrils and you're in a relationship and they want you to share your deep thoughts, you're triggered, you know what I mean? And so because you have that, downstream anticipatory anxiety. So are we screwed? If we chose the wrong parents early in life, are we screwed, or is there something we can do now?
So unfortunately, I think we've been giving some wrong messages, and I don't think we're screwed. But I think some of the interventions that we've been using I think they may be helping in ways that people don't understand. They may be. I think they are. I take that back. They are helping, right? But some of the benefits isn't exactly what people think they are on the outside. Community and relationships absolutely decreases threat when people start to learn that other human beings can be safe in the context of that. And when you have a shared sense of community, so even if I gave intranasal oxytocin to people, I can increase in-group bonding in response to something if they believe that they're a part of this, which is interesting.
Larry, can you take that to Congress and start spraying it up nostrils or something?
So they can work across the aisle?
Across the aisle.
It actually
no, but so you're saying that the oxytocin just kind of mellows out the stress hormones, right?
It clearly, we know it clearly has protective effects from chronic pain. So that's interesting, right? So some of the things we may be doing, helping people with the context of relationships and stuff like that clearly has some benefit for them. The other things when we start talking about harm reduction, so people talk about harm reduction, right? And it makes a lot of sense. So you talk about harm reduction, you're really trying to keep people alive long enough so you can make effective long-term strategies of changes. Right. But what you've also done is, and nobody's talking about this, right? What you've also done is you've sent a message that they're no longer a threat to us. So I'm going to have a harm reduction model, and your patterns of behavior are not considered morally corrupt. You're no longer being the arrow pointing at you. So you're actually decreasing threat within the interface. So when you're saying, I understand that you may have patterns or habits of learning, they're not saying it like that, but that may lead to you to do things that could be really harmful. And I will continue to have your back support. So when you think of needle exchange programs, and you think about even injection sites where people can go, what you're building is actually not, so people think the treatment is the safety in the fact that, yes, on the outside, that's exactly that, but you're also building community in the context where they're now coming into a non-judgmental, so that is a therapeutic intervention that nobody's even thinking about. But that's a therapeutic, that may actually be a really powerful intervention. So suddenly you're not this bad human being, you're this human being who's struggling with patterns of trying to find a space in which to create safety. That's a safe space, which is really interesting to think of the layers of intervention that may be happening and the shift in the paradigm. So that's interesting. The other thing that you and I have talked about in the past is even understanding things like what is a coping skill. So a coping skill doesn't change the user interface at all. I'm still saying you're still seeing threat, and I want you, instead of doing this, so that's a harm reduction model too, a coping skill. So I want you to go off and do something, other pattern of behavior. I want you to do some other pattern of behavior. The long-term goal is to reduce the most adverse pattern of harmful behavior.
Yep.
Then to use a different pattern of behavior. But the long-term goal is to change the complete interface so that the thing that you see as threat is no longer a threat. And there is research on this. So when you ask me, are we doomed? We're not doomed. We're not doomed. That what we need to do, and that's one of the goals of what you and I have been working on obsessively for years, is how to create the necessary cognitive bias with the downstream stuff shift. So the opposite of frustration, intolerance, is people using words like delayed gratification. Where is and why is, so you can talk about different models of doing that, but how do we create a succinct cognitive bias where that's a natural output and not something that we just do?
Yeah.
And that's one of the big things that you and I have been working on.
So another way to say this then may be that we are not doomed because what we label as negative was learned, and what we will do differently will be learned too, in terms of new patterns of perception and attributions to the world.
Steve, the one thing I like what you're saying right there, and when you and I get talking, it goes on forever, I know, but the one thing I wanted to say is, so the new patterns, right? We can only create a new pattern if I ask you not to make that your focus. And I agree that that's not going to be your focus, right? So that's this is a big pivotal change that I want people to get, because when people come in to see a therapist or a psychiatrist, what do? Is we track the interface that we have all agreed is threat. So when you come to me, I do a mood tracker. How is your depression? How is your anxiety? I have agreed that what you have seen was built to be truth. And in this new model that we're thinking about is, you actually, I'm not asking you to track those things. We're asking you to now start tracking different things in the environment. And that shifts that cognitive bias to one that is going to be vastly different. And we treat it like a language. If you want to learn a language, the best way to do it is to do full immersion. So the model is a full immersion process in which we're no longer allowing you to part-time speak the outdated way of seeing the interface. We're now saying, this is what we will speak to you. We will speak to you. People say, oh, so you're not going to be tracking the thing called anxiety, threat. You're not going to be tracking any of those things. No. The most effective way to learn a language is full immersion. The most effective way to create a new, more adaptive thing is to see the environment in a vastly different way. What is your connections? What are your relationships? And then in the process, you start to create that cognitive bias. And that bias is the thing that creates all the downstream stuff. So when you mentioned oxytocin, it is literally within the construction that oxytocin gets released. Oxytocin is released. Dopamine, serotonin, all those things are released within this bias. So threat, non-threat. Non-threat creates the entire molecules of emotion that allow you to have the most adaptive physiological responses, longevity of life, and it can only be built within that cognitive bias. And it can't be built within our traditional models of psychology and psychiatry that are only tracking
Yep.
all of the things that we call sickness.
So Larry, we'll be doing this workshop, and I'm trying to decide whether to hand my credit card over so that I can get charged, put this on PayPal. What concrete things will someone who attends this workshop actually take away? Is it going to be theory so that when a client comes in that we say, let me give you 1 hour of theory here that we're going to be dealing with? Or will they have something concrete that they'll be learning that they can take away?
We're going to actually introduce what we've been working on for several years as a way of distilling down what we believe is the way of unifying and understanding how psychiatry, biology, and psychology merge together to create our current patterns. And how can we reduce, or how can we simplify the various interventions that we have seen, and what is the real mechanism of creating change? And so that's going to be the thing that we're going to be able to do for people, is to get them to really understand this, which is really exciting. I'll tell you one really interesting example of this, Steve. I treated a patient recently with a conversion disorder. And the people have at times wanted to focus on the conversion disorder. They want to literally, whatever the manifestation is of that pattern of behavior, whether it's paralysis, whatever it is, vision, you name it. What I invited everybody to do is to see that as a pattern of behavior of seeing some level of threat in the environment that was necessary and adaptive because it created the necessary escape.
Right.
I have this, I escape threat. I have this, I escape threat. We have animal models of I have this, I escape threat. So like tonic immobility you could hold a bird down, you could have tonic immobility. They could literally so conversion disorder, threat. What I did though was I asked them to create the interface where this person did not see threat, we did not speak threat, and I did not acknowledge the pattern of behavior. And when the person used the language that was more adaptive, the way of communicating, I responded to that. When you consistently respond to that language, and we use the word language for a real reason, because human-to-human interaction is communication at all levels. Humans interact is a form of communication, and we know this, and we talk about things like mirror neurons, right? So, but what we know is all forms of human-to-human interaction is a form of communication, whether it's pheromones, mirror neurons, body language, things you would never even think about, but it's chronic human-to-human interaction is a form of communication. So it's spreading information because we were hypersocialized. So when you think about human, and that's one of the things I want to really make clear for people, is that what we're teaching people how to do is create habits, new patterns of communicating effectively into the world that's going to have long-term health benefits for these people. And then once people get that, what is the model of the most adaptive practice or patterns of self that we can teach people? And how is that cognitive bias produced? Because the cognitive bias is the expression of this pattern of communication.
Done. Yeah. Okay. Well, Larry, thanks so much. There's a boatload more. I mean, we have 2-hour conversations every other day for like how many years, but in the workshop, we are going to be really focused and give some really concrete kinds of things that they can learn. It will require kind of a different way of looking at, a different way to look at things, but in a way that will give people more freedom and really not more freedom, but just really basic freedoms and choices in life that they may think that they don't have, right? So thanks so much. I'm looking forward to it. And any last words you want to say?
No, thank you, Steve. I appreciate it.
Okay. Thanks so much. And everybody, we look forward to seeing you at the workshop. So look on Facebook, on YouTube, and you will see ads about this. Okay. Thanks, Larry. Have a great day.
Thank you, Steve.
Bye-bye.